Athol, before you start, I just want to personally thank you for accepting to chair this session with lovely speakers. Thank you for what you're doing for sarcoidosis patients. And I would just say that you are the WASOG president-elect at the moment, future president of WASOG, and I would just to mention the key and most important ILD and sarcoidosis specialist in Europe for many of us. So over to you.
Thank you very much, Vasilis. I think I want to move us very quickly through introductions because we have a great deal of substance to follow. So let me introduce all three sessions right at the start. The first two sessions relate to what has changed in sarcoid diagnosis and sarcoid treatment, and they'll be addressed by two sarcoid leaders, Anjali Crawshaw from Birmingham, Simon Hart from Hull. They were both core members of a very active and enjoyable BTS group that developed guidance in sarcoidosis, a document that has had major international feedback. I'm happy to say all of it positive. And then we're going to hear from a marvelous group of nurse specialists, Charlotte Hogben, Benedetta and Melissa. I'm not sure who amongst this troika is actually going to be opening that session. But without further ado, Anjali, would you like to kick off on what has changed in diagnosis and detection of sarcoidosis?
Hi, thank you for inviting me to speak. Let me attempt to share my screen. Hopefully that is working. Can you see the right screen?
Yes, we can see it.
Great, thanks. So my name's Anjali Crawshaw. I lead the Midlands Sarcoidosis Service running out of Birmingham, and I'm a consultant respiratory physician. Thank you to Vasilis and to Sarcoidosis UK for asking me to speak about diagnosis and detection of sarcoidosis and really what's changed. Now, right, so have no conflicts of interest. I'm going to talk through introduction to the guidelines, diagnosing pulmonary sarcoidosis, the history and clinical features, imaging, the importance of the MDT, and then talking about really what's changed compared to previous iterations. So for 20 years or more, we've been working with the American Thoracic Society, European Respiratory Society, and World Association of Sarcoidosis and Other Granulomatous Disorders statement. And just prior to the pandemic, it was very apparent to everyone that we needed to update our guidelines and statements. And in rapid succession, the BTS, the ATS and the ERS all published consensus statements or guidelines looking at the diagnosis and treatment of sarcoidosis. And these statements were MDT, so multidisciplinary consensus statements, looking at systematic review, meta-analysis, with the aim of summarising the best available evidence. These teams were made up of respiratory physicians, allied health specialists, statisticians and patient representatives, very respiratory heavy, however. So I'll summarise the recommendations now and talk through them as we're going along. But the recommendations, as ever, are taking a clear and history. That's key. Typical or long-standing presentations with supportive imaging may give some diagnostic security without the need for further tests. If not typical, MDT is absolutely crucial, so discussion amongst respiratory physicians, also specialist cardiologists, neurologists, rheumatologists, really to make sure that we're getting the diagnosis and ongoing investigation and treatment right. There is an argument for observation versus going straight to biopsy, mindful always that we need to exclude other causes. And obviously, we're working for our patients, and your involvement in our decision making is key. So the evidence for used by the teams were low quality. There's been no major leaps, rather inching forward in the guidelines. And so why low quality evidence? And I'm sure this will be talked about later, but it's not for lack of interest. It's an infrequent condition, sarcoidosis, with huge variability in organ involvement and the extent of disease. There's poor correlation between symptoms, outcomes, and the extent of organ involvement, and it can make it difficult to obtain reproducible data. You don't get nice, neat patient cohorts that are required for drawing secure conclusions in research studies. So you need very large numbers of people to be involved. The diagnostic conundrum really is that there's no standard or single test, and our diagnosis of sarcoidosis remains based on a compatible clinical presentation. So looking at patient history, what's been going on, what are the symptoms, looking at the laboratory findings, imaging, x-rays, and supported by biopsy samples which may represent granuloma in one or more tissue samples. So a granuloma is a collection of immune cells, specialist white blood cells that cause their mischief in a couple of ways. One by giving causing inflammation in the organs, and also by causing physical issues. So for example, if it's in the conducting system of the heart. And the other important factor is we do need to exclude other causes. And so our diagnosis of sarcoidosis is based on a constellation of factors, and the diagnosis is never completely secure. The history is absolutely crucial in our diagnosis and the diagnostic pathway. There are a large number of cases that are incidental and without symptoms. They're picked up on investigation performed for another reason, an X-ray done for work purposes, or after a road traffic accident, for example. There's a typical history, and I'll talk about what I mean by that in a moment, but that can lead to quite straightforward investigation with imaging and gives us a reasonably secure diagnosis. There are less typical histories which require more complex investigation, more thought, and an MDT consensus. And then there's the insidious onset or slow creeping onset of symptoms that can be difficult to piece together and can lead to a delayed diagnosis. From a respiratory point of view, shortness of breath, dry cough, and occasionally chest pain are seen. And the other important thing to tease out is, have there been previous similar episodes? Other clinical features, sarcoidosis can affect almost any organ in the skin. You can get particular rashes, nodules, eyes, get inflammation in the eyes, joint pain, joint swelling, muscle pain and inflammation. There's heart and neurological symptoms that I know my colleagues will be talking about later. Kidney involvement can result in high calcium. Blood involvement can have low blood counts. And so there are lots of blood tests and things that we can do to give us pointers to things that may be going on. Again, in the history, it's really important to exclude other causes and also to think about extrapulmonary involvement, so involvement outside the lungs. We need a clear occupational history. Has there been any exposure to beryllium or silica, which can look very similar? TB, if you've been exposed to TB can look very similar to sarcoidosis, and it's important to think about and potentially exclude that. Is there a family history? And I won't dwell on the eye, cardiac and neurological symptoms because this will be spoken about later. But this is an iterative process. We're always thinking about what other organs are involved at the start and at each point, at each review subsequently. When the first examination and even in subsequent examinations, we often find that the respiratory examination is normal, and it's not really a reliable measure of disease extent or in fact the amount of morbidity caused by sarcoidosis. And similarly, unless there is fibrosis, breathing tests often don't reflect disease activity or morbidity. We measure blood tests, including blood count and liver and kidney blood tests, really to point to other organ involvement. And the first imaging we do is a chest X-ray. So in terms of typical history, what I mean by that is this Lofgren syndrome, which comes with a good prognosis, and it's a classical constellation of symptoms. You get erythema nodosum, which are tender red nodules on the shins, some arthritis, fever, and lymph node swelling in the center of the chest. And with this constellation of symptoms, you can make quite a clinical diagnosis with the suggestion that this further recourse to biopsy is not necessary. When there is more on the chest X-ray, when there's something that's not quite typical, that's when we want to think about this more, do CT scanning, have MDT discussions. So on this X-ray, there's a few extra dots and things telling us that there's maybe something extra going on. And so that's when you'd go on to have a CT scan. This is a normal CT scan. Person's lying on their back, head away from the screen, feet towards us. And this is a slice at the center of the chest, just after where the airway splits into two. And there are typical and not typical patterns. And really, based on whether there is a typical or non-typical pattern, this is when we need to think about things further. Where there is atypical or not typical patterns, this is when we want to discuss in the MDT, so multidisciplinary team meeting with colleagues who both specialise in sarcoidosis of the lung and in other organs. And what we want to do is discuss the case history. What's our degree of diagnostic certainty based on X-ray or CT imaging, based on other organ involvement, based on our laboratory tests. Can we agree with a degree of diagnostic certainty without recourse to biopsy? Can we observe closely, or do we want to biopsy? What's the risk benefit of doing a biopsy versus close observation? And really the key is excluding alternative pathology, and that's often the driver for pursuing a biopsy. Our aim is to keep treatment to a minimum to ensure that there are no side effects from drugs. We want people to be safe without progressive or dangerous disease and without risking side effects of treatments. So when we talk about biopsy, there are various options, and one of the moves in the more up-to-date guideline is that biopsy isn't always necessary, and when it is necessary, perhaps we should be looking to more peripheral sites. So instead of going straight for a biopsy from within the lung, can we do a biopsy from a lymph node in the neck? And recent data suggests that actually a lymph node biopsy from the neck, even when those lymph nodes aren't enlarged, can perhaps give us a degree of, give us granuloma and help in our constellation of factors that give us some diagnostic uncertainty. The old guidelines 20 years ago were written prior to the widespread availability of ultrasound guided bronchoscopy biopsies, which is the EBUS biopsy that we talk about. Prior to that, we were doing biopsies via a bronchoscopy, but without being able to visualize or see the lymph node. Now, these are we get a better result, we're more likely to make a diagnosis with these, and these have moved to first line if we need to do a biopsy and there are no peripheral sites for us to take a biopsy. There are other options for biopsies. For example, if the lymph nodes aren't enlarged, we might want to take a biopsy from the spongy bit of the lung, a transbronchial biopsy. And some centres have cryobiopsy available, which is where you can take a slightly larger sample from the spongy bit of the lung. Other organs may be involved and may point to more straightforward biopsy site, for example, the kidneys or the nasal mucosa. And really, we are using these biopsies to help give us diagnostic security, seeing the granuloma and also excluding alternative causes. Additional tests, well, we would want to make sure that people consider an eye examination either with an optician or an ophthalmologist. Ocular sarcoidosis is seen in 20 to 25% of people and can have vision threatening complications, and so we would advise people to have an optician appointment. We would want to screen with an ECG, and then if there are other suggestion of organ involvement, other tests may be done. So in terms of a diagnosis summary, if we thought there was Lofgren syndrome or a very chronic stable CT imaging that looked like typical sarcoidosis, then we don't necessarily need to do a biopsy. We can monitor with blood tests, with breathing tests, and with chest X-ray. And if you're well and otherwise well, actually you can be discharged from regular follow-up. If there's progression or things aren't quite right, then that's when we would consider biopsying or treating. If there isn't a typical picture, that is when you would want to think about getting a biopsy. Is there anything that we can biopsy outside the lung that's more straightforward to reach? And if so, biopsy that first. And if it's unhelpful, that's when we would consider doing a bronchoscopy and doing a biopsy from a lymph node in the chest. And if there isn't an easy accessible site, then there are different types of biopsy that we would do with either the ultrasound, with a wash, or on occasion a biopsy of the spongy bit of the lung. I think more importantly, it's important to revisit our evidence for sarcoidosis, revisit our evidence for disease activity regularly. The ATS statement suggested perhaps annual review was sufficient, but actually it may be better to review people much more frequently so that we can observe off treatment with a greater degree of certainty. And this gives us the ability to monitor for danger signals early, such that we can keep people off treatment and start as soon as we feel that that's required. People may need further imaging or biopsies if the clinical picture changes, and regular review allows us to detect that. What's new, what's changed? Well, the newer guidelines suggest, unlike the previous ones, that biopsy is not always required. If the disease is typical in its presentation or long-standing at first presentation to a respiratory or sarcoidosis centre, then biopsy may not be necessary. We now have ultrasound-guided biopsy, the EBUS, which has a better pickup rate, and so the introduction of that into the diagnostic algorithm is new. There's a move away from single clinician care of sarcoidosis to a much more MDT approach. Instead of working in silos with a rheumatologist looking after a patient and a respiratory physician independently looking after patients, with us working together as an MDT, it cuts down the number of appointments, increases the collaboration, and ensures that patients don't have either excess appointments or excess treatments, we're much better at identifying involvement outside the lung. Working together, it makes us think about and identify things more efficiently. And then identification of danger or damage is something that we are keeping a very clear eye on. So what are the take to your appointment messages? Sarcoidosis still is a diagnosis of exclusion, and we may not need to biopsy every patient who walks through the door. We do need to exclude other cases and other causes, and our rates of biopsy depend on where you live. If you live in a tuberculosis prevalent area, that will drive up the rate of biopsy, for example. Biopsies can increase our diagnostic security and increase our confidence in observation and treatment. But mostly, we want you to talk to us. We want you to be part of the decision-making process when we're deciding about follow-up biopsies, not biopsies, CT scans. We're happy to discuss, and just because you said something to us on one occasion, that's not forever. You can change your mind. So, thank you.
Thank you very much, Anjali. I think that we will have questions after Simon's talk to cover both of your sessions because they are a continuum. Very nice presentation. I will just say that it's important to reinforce that biopsy decisions are a partnership. And I do just want to say that over the years, it's become obvious they tend to be much better decisions if there's a discussion between the person who might undergo the biopsy and the doctor, with that decision being made jointly. But we may come back to that. Simon, updates in the treatment of sarcoidosis.
Thank you, Athol. Thank you, Vasilis and the organisers for inviting me. Just loading up my screen, which I'm hoping you're able to see. Please shout if you can't.
Don't worry, it's there.
It's there, very good, thank you. So now a talk to follow up on Anjali's talk, a talk about treatment, again focusing on recent publications from the learned societies that we've already heard about, and in particular the one from the British Thoracic Society and the document from the European Respiratory Society, which focused particularly on treatment of sarcoidosis. And the aim of these documents from the learned societies is to share best practice, try and reduce unwarranted variations in care between different centres and different parts of the country. So before we focus on some of the key messages from these documents about treatment of sarcoidosis, let's think about the general principles of sarcoidosis treatment first. And I'd like to illustrate this, if I may, with a clinical case, a real case. So this gentleman came to see me with about 2-month history of cough, breathlessness, flu-like symptoms, and aches and pains. The chest x-ray showed a combination of enlargement of lymph glands in the center of the chest and changes within the lungs. A CT scan confirmed the lymph gland and lung changes. And this patient went on to have a transbronchial lung biopsy, actually, which confirmed the characteristic pathology of sarcoidosis, which is these granulomas, these collections of immune cells in this rather organized fashion. So thinking about this patient, what's the best treatment? Bearing in mind that he doesn't have anything that looks particularly immediately threatening to his health or anything that's going to lead to immediate disability. And his symptoms, whilst troublesome, are not terribly impairing his quality of life. We opted to treat with nothing and to adopt a period of observation. And indeed, after a short period of a few months, the patient was feeling very much better and his chest x-ray looked very much better and he had no further problems in the long term. So the point here to consider at the beginning is that not all patients with sarcoidosis need any treatment at all. Some forms of sarcoidosis will get better by themselves. They may not completely go away, but that might be quite acceptable. And a period of observation is often a good option. And this makes it difficult, the fact that many cases of sarcoidosis appear to be self-resolving. This is one of the difficulties in assessing new treatments of sarcoidosis, because if we'd given this patient some treatment, we'd be very pleased with the result, the patient would be very pleased with the result, and we'd all go away thinking that the treatment that we'd given was an effective treatment for sarcoidosis. Now, this is not a new problem. This is an old problem that's been recognized for a long time. Here's a quotation from the American physician Louis Siltzbach, who did a lot of work in sarcoidosis in the 1950s and 1960s, who said, "The cause of sarcoidosis still eludes us, as does the definitive treatment. Part of the difficulty stems from the unpredictability of spontaneous remissions, that is, the disease improving by itself. And these then account for the many successes reported with all sorts of strange, weird and wonderful treatments listed there in blue, which we don't use anymore because we know that they don't work, but the same problem applies to assessing new treatments." So some sarcoidosis doesn't need any treatment. However, sometimes sarcoidosis is in a dangerous place. The heart or the nervous system spring to mind. Sometimes there's lots of disease, and sometimes after a period of observation, rather than getting better, the sarcoidosis in fact gets worse, as illustrated with these x-rays on the bottom. So we're then in a situation where we might want to treat the sarcoidosis. This is where the two documents from the BTS and the ERS have been particularly helpful, because they really clarify what the reasons are that we would want to treat sarcoidosis. When would we treat sarcoidosis? We treat it if it's dangerous, that is, there's a risk to life or a risk of permanent disability if we do nothing, or if the patient is feeling so bad with their symptoms that their quality of life is terrible. Now, the treatment approaches may vary depending on which of these situations arises, and we'll come back to that. But these are the two situations in which the likely benefit of treatment outweighs the potential downsides of treatment, and all treatments have a downside, and we'll come to that as well. So the documents have been very useful in clarifying this for clinicians treating people with sarcoidosis. So if we're thinking about treatment of sarcoidosis, let's just go back to have a think about what actually are we treating. Here's another picture of a biopsy from a patient with sarcoidosis, this time in a lymph gland, showing these characteristic collections of activated immune cells in these granulomas, each a few hairs breadths in diameter. Within these granulomas, we've got two principal types of cells. We've got the large pink cells, which are the macrophages, and we've got the little blue cells, which are lymphocytes. And these cells form a granuloma, and that granuloma is maintained and persists because of chemical signals released by these cells and by neighboring cells that keep these cells in a state of persistent activation. One of these chemicals is TNF. We'll come back to that, but there are others as well. And what we want to do is to block these chemical signals to achieve resolution of the granuloma and therefore improve the patient's sarcoidosis. And when the granuloma resolves, the cells move away or they die. Now, the best drug that we know of for blocking all these chemical signals are steroid drugs. And that's because they block many of these chemical signals. We don't need to know or guess which of the chemicals is most important. The steroids block them all. This wide-ranging effect of steroids also relates to some of their problems as well. So let's have a think about steroid drugs. What we're talking about here is steroid drugs related to the hormone cortisol, which is produced by the adrenal glands, these two little hats that sit on top of your kidneys. They produce cortisol, a steroid that was first identified in the 1940s and rapidly realized that if you inject synthetic cortisol into patients with inflammation like bad arthritis, patients improved. And nowadays we use for drug therapy synthetic derivatives of cortisol, mainly prednisolone in tablet form, sometimes intravenously methylprednisolone. So in summary, steroids work in sarcoidosis. The documents that I'm talking about are both recognize that steroid therapy is the first-line treatment. It doesn't cure sarcoidosis, but it works in sarcoidosis by reducing those chemical signals, suppressing the inflammation, and they do that, and steroid therapy works pretty fast within a few days. So that's all good. It would seem that steroid therapy ticks all the right boxes for treating sarcoidosis, or at least suppressing it. Why don't we use steroids then for all people with sarcoidosis? Well, because all treatments have some downside. And for some patients taking steroid therapy, the treatment may be worse than the disease. And that's particularly people who take steroids in the long term. And by that, I mean longer than a few months, and particularly if they take higher doses. And the side effects are those of a medical condition called Cushing's syndrome, which is due to overproduction of cortisol, usually by a tumor in the adrenal gland. But giving steroid tablets for a long period of time has the same effect. Another important thing to consider is that a number of studies have shown that patients who start steroid therapy for sarcoidosis treatment, about half are still taking steroid tablets 5 years later. So people can get stuck on long-term steroid therapy. So here, the British Thoracic Society document has again been very helpful because whilst emphasizing that steroid therapy is the first-line treatment, it introduces some nuances and particularly a focus that low-dose therapy, therefore minimizing side effects, may be appropriate in certain situations. For example, if you're predominantly treating a quality of life issue, or if you're treating and starting to treat kind of chronic insidious disease, you can get away with lower doses, so 10 milligrams a day, for example. Higher doses in more acute or dangerous disease, fair enough, but a maintenance dose, that is a long-term dose if required, should be aimed to be less than 10 milligrams per day, and attempts at withdrawal of treatment should be made after 6 to 12 months. So these nuances about dosage of steroid therapy and a focus on lower dose are particularly important. Now, there are some people who need long-term therapy for their sarcoidosis. It may be that a trial of withdrawing steroid therapy doesn't work and the sarcoidosis comes back again. What to do then? Well, there are two options then, either to continue on a long-term dose of steroid, ideally less than 10 milligrams per day. But if that's not possible, or if there are other reasons, then we may need to add a second-line drug, so a second choice drug to the steroid therapy. So these drugs are immunosuppressants, so meaning they generally suppress the immune system. And often they're used because the idea is if you add one of these non-steroid second-line drugs, then you'll be able to use less or ideally no steroid at all. That is, they are steroid sparing. In the UK, the two commonest drugs used in this situation are azathioprine or methotrexate, but there are others such as leflunomide, mycophenolate. These drugs are not steroids, they work in a different way. They work by interfering with DNA synthesis. So they stop cells from making more DNA, and a cell needs to make more DNA when it needs to copy its DNA when it's dividing from one cell into two cells. And in the immune system, this is important, particularly with the biology of lymphocytes, these little blue cells around the edges of the granulomas, because when there's an immune response or the immune system responds, one of the things that happens is these lymphocytes then divide and proliferate. So there are more of them. And that's one of the ways that the immune system has memory, so it's able to recognize something a second time after it's already seen it once. And that's, of course, important in a vaccine response as well. So this is one of the reasons why patients taking immunosuppressants such as azathioprine or methotrexate may not mount a strong immune response to vaccination, including COVID vaccination, for example. So that's another potential downside of these particular drugs. Now, the European Respiratory Society document took an evidence-based approach and assessed the quality of the scientific evidence for all treatments for sarcoidosis in various different organs. And I've just picked out a summary of what they concluded about immunosuppressant use, so azathioprine or methotrexate, in various different organs listed on the left. But what I'd like to draw your attention to is the column on the right, which is the quality of the scientific evidence. And as you can see, it was generally very low. And the interpretation of that is that the true effect of the drug is probably markedly different to what we think it is. So the scientific evidence is weak, it's very low. And so the decision about treatment with these drugs, as with treatment with steroids, needs to be made with good clinical judgment but in discussion with you, the patient, about what we're trying to achieve, what the benefits are, and what the potential downsides might be. And again, this is emphasized particularly in the British Thoracic Society document, which focuses very much on the patient at the center of the treatment decision-making, and the concept of shared decision-making, with statements such as, there is often a fine line to making the decision to start drug therapy, and all patients should be fully informed and at the heart of that process, and that in essence, treatment of sarcoidosis, be it with steroids or second-line drugs, is a risk-benefit discussion, with a decision made by the patient informed by the clinician about what you're trying to do, what the potential downsides might be, and then as part of that negotiation and that deal, what are we going to measure to see whether the treatment's working, to assess treatment response? What are we going to do at that stage if the treatment's working well, or what are we going to do at that stage if the treatment's not working so well? So that negotiation includes all of that plan. And the document has been particularly helpful in emphasizing the role of the patient at the heart of decision making. So that is one of the things, one of the main things that's changed as a result of these documents. What about other treatment options? Well, some patients, first-line steroids, second-line drug, still not working properly. What other options have we got? Well, we've heard about the chemical TNF, which is important for granuloma formation and maintenance. Drugs that block TNF have been used for the treatment of rheumatoid arthritis for many years. These drugs have then been tried in people with sarcoidosis. And here is data from one clinical trial of the TNF blocking drug infliximab in people with lung sarcoidosis, who were treated for 24 weeks, so about 6 months. And the outcome was their lung function, which is presented on the vertical axis here. And compared with the placebo in the black dots, the patients treated with 2 different doses of anti-TNF therapy had an improvement in lung function, which was sustained. But the actual size of that improvement, it was relatively small, only 2 to 3% improvement in lung function. But of course, these average figures hide the detail, and the detail is that some patients respond very well and some patients don't at all. Here's an example of a good response to a year's treatment with TNF blocking therapy in a patient with chronic sarcoidosis in whom all other treatment options had failed. And in this patient, there's a good improvement in the chest X-ray appearance, and there was a good improvement in lung function tests to go along with that as well. So for some patients, TNF blocking therapy is a good option. And this is recognized by NICE, the body that advises the NHS what it can and can't afford. These treatments are a bit more expensive, and that can sometimes be a challenge. So that's all I'm going to talk about in terms of current treatment. Just a couple of slides to finish up then. And one is about new drugs in development. And I'm encouraged, and I think it's great, that the pharmaceutical industry seems to be taking sarcoidosis more seriously and recognizes it as an important disease as a target for treatment. And these are 2 trials from 2 American companies, but both of whom are planning to trial their drug for the treatment of sarcoidosis, not only in the US, but also in the UK. So Kinevant's drug blocks another chemical that maintains the granuloma called GM-CSF, and aTyr Pharma's drug blocks a molecule called NRP2, which is important for inflammation. So I think it is good and a good option for everybody that hopefully more patients are going to have the opportunity to participate in clinical trials of potentially new effective treatments. So a summary slide, what has changed in terms of the new guidance document? I think the 3 key messages are the emphasis on the reasons to treat dangerous disease or a poor quality of life, that the dose of steroid can be tailored according to the individual person's situation and the level of urgency, and for some patients a low dose minimizing side effects may be adequate, and that a negotiation with the patient should be at the heart of all treatment decisions. I'm going to finish up there. Thank you for listening.
Thank you very much, Simon and Anjali. I've cherry-picked a question for each of you from the chat. Simon, since you're on the stage right now, there's a request for clarification on the shift from first to second line therapy. And the question is broadly, is there a change from steroid to second line therapy? Do you use it in combination? And I'm going to add a further question. Is it ever justified to start with second line therapy and not use steroid at all?
Well, thank you for all those extremely difficult questions, Athol. And I guess the first thing to say is, as emphasized, the scientific evidence base doesn't help us answer those questions. So we have to try and answer those questions with clinical judgment and in terms of patient preference and what the patient wants to do. The principles would be that steroids work fast, but the second line drugs do not work fast. They work slowly, so they take several months to kick in. So if you want to achieve control of the disease in a reasonable time frame, then you have to start with steroid therapy. And so the usual thing to do is to start with steroid therapy, try and bring the dose down, try a withdrawal of treatment. And if that's not effective, then you may have to continue steroid therapy with the addition of usually a second line drug. So the two then are used in combination, and that may allow the steroid then to be removed such that the patient then continues on longer term treatment for years with the second line drug alone. So that would be the typical sort of situation. I think when we're hearing later on about neurosarcoidosis and cardiac sarcoidosis, which are more urgent and potentially more dangerous, there may be an argument to go in with both drugs together at the beginning.
Thank you, Simon. We could, of course, talk about this at great length, but sadly, time is short. So, Anjali, I'm going to ask you about what signs of danger would you focus on at the first presentation of sarcoidosis? This is a very good question from the Q&A chat.
So in terms of respiratory symptoms, really breathlessness that has and in terms of the chest x-ray and things, it's quite difficult because the chest x-ray that Simon presented actually showed a lot of patchy change on the scan that can look quite alarming, but actually when you go on to image it further, it looked like there was a lot of inflammation without scarring. So I suppose for lungs, things that we would be worried about is if there is suggestion of scarring on the scans. For other danger signals, we'd be worried about organ involvement in more dangerous places, so in the heart, or if there was neurological involvement. Those are the things that we're looking out for. But you can have very, very profound changes on imaging without actually there being a concern that there was that we need to start treatment straight away. So it's very difficult to make a snap decision at one point, and this is why very, very close observation is really important.
Thank you, Anjali. And just to emphasize, especially heart disease, which of all the other organ involvements is perhaps the single most frequent danger, and the danger of focusing on the lungs and missing evidence of cardiac disease. I think, unfortunately, again, we could discuss this at some length, but I'm going to have to say, in the interests of time, thank you very much indeed to both speakers. I hope you can separately discuss on the chat one or two of the questions that have come up. But in the interests of a civilized break, I think we now have to move to the Royal Brompton Hospital Nurse Specialist team. And I believe that Charlotte Hogben is going to speak on behalf also of Nadetta Vitry and Melissa King. Charlotte, please go ahead.
Thanks, Athol. So yes, we're a team of 3 nurses here at the Royal Brompton, myself, Benedetta and Melissa. And we sort of have a number of roles as the nursing team in terms of supporting patients, GPs, other specialists and making arrangements for treatments. So we have a dedicated advice phone line, which any patients who are under the care of the Brompton have access to. It's on the top of all clinic letters next to my name, and that phone line can be used for advice between appointments. So often if people have been very stable for a period of time, they might have reasonably big gaps between appointments, but if they then have changes in symptoms or concerns in between those appointments, our advice line can be accessed in order to discuss their concerns, discuss issues and see whether we need to expedite a follow-up appointment. That line can also be accessed by GP practices and specialists in other hospitals if they need some additional support and advice. And obviously, as a nursing team, we don't necessarily have all the answers to questions that might come in, but we are able to take those queries to the consultant body to discuss and get advice from them, whether that is simple advice we can pass back or whether that means bringing people in for additional tests and an earlier review, depends on the situation. As well as that phone line, we also have an email address, again, at the top of all of the clinic letters, which can be used for sort of more non-urgent, I would say, queries to come in via email if people have got questions that they want to be answered, which we can either answer ourselves or pass on again to the specialist for further advice. Another large part of what we do, though, is arranging treatments for people. So that might be day unit treatments where we arrange IV therapies up on the day unit, IV steroids, or treatments like infliximab. But also for some people who don't tolerate oral methotrexate, for instance, we've now got a service setting up people to be educated on how to administer subcutaneous methotrexate as necessary, and we can arrange that via our day unit setting. Also, with many of these drugs, particularly methotrexate, GPs often are unable to prescribe or unable to take on the prescribing and monitoring of the medication. So another part of our role is making sure that people, if their GPs can't, still can access these treatments by setting up deliveries via our healthcare at home service and by providing advice and support in terms of blood results and blood monitoring to both patients and GPs. And also we're here to help with any issues that people might have in terms of side effects from any medications that are started. So essentially our main role, I suppose, overall is that liaison between patients and GPs and the specialists within the hospital, because the consultants can't be available for every query that comes in, but they are available for us to discuss all those issues with, and we're able to get advice and get back to you. So yeah, please do look out for that phone number and email address, as I say, at the top of all the clinic letters, next to my name, Charlotte Hogben, right at the bottom of the list of all the consultants' names. And do feel free to get in touch if you've got any concerns in between appointments. There's also on those letters the email address for our administration team, very similar to our email, ILD admin, and they're available to help chase up any letters or issues with appointments and things as necessary. I can see a query has come in about using these elements of support if you're not a patient at the Brompton. Unfortunately, we can't offer advice if you're not known to our service and we don't have your records here. So you should, ideally, there should be somebody within your own service that has a similar role. But if there isn't, I think the other option, of course, is always to go via SarcoidosisUK, who have a sort of similar support setups and could potentially link you in with the right person if you don't have that via your local service. But that's all I was really logging in to say, really, is to tell you what we can do and what we can offer. But I think now it is time for a break, unless Athol's got anything further to say before then.
Thank you very much, Charlotte. I want to just give you one question. The question is, are we able to use this service if being treated outside the Brompton?
Yeah, so that we can't offer direct advice to people who are not under our care. We don't have access to all those medical records, so we wouldn't be able to offer proper advice. So the best thing would be to contact your local service, who does have your records, and ask for advice that way. I do appreciate that in some areas there may not be as much support, and that's where I think charities like Sarcoidosis UK come in as a really helpful resource as well for you.
And as a second question, this one's from me actually. If you had to cherry pick the problem that patients most frequently bring to you, where you feel you make the greatest difference, what would you say about that? It's an easy question, isn't it?
No, that's a very, very difficult question. I think one of the biggest problems, particularly in the sarcoidosis cohort of patients that people have, is determining for themselves and in conjunction with the GP what symptoms they're having might be related to their sarcoid, or maybe completely unrelated. And often that's a very difficult question for us, for the patient, for the GP, and even for yourselves. But we can help sort of work through some of those questions and try to help with that, because often I think GPs are a little bit stumped when it comes to trying to work out if it's related to your sarcoidosis or not, and they'll often say, oh, I'm not sure, call the Brompton, and that's really what we're there for, to then have a chat through those issues and see how we can help.
I'm glad you actually gave that particular answer, Charlotte, because you're absolutely right. Even sitting in a sarcoid clinic, very often the assumption has been made that all symptoms are due to sarcoidosis. And it's astonishing how often, especially in the dual expertise clinics, that it becomes clear that symptoms thought to be due to sarcoidosis actually relate to separate problems. So I can see how difficult that must be, answering on the fly, as it were. But certainly you've developed huge skills in that regard. I'm very aware of that, and your whole team's been admirable with that particular issue. I think we do, unfortunately. I saw Vasilis's screen flicker on and off, and I think that's a signal that we have to bring this to a close and move to a break. And he's come on now, so I shall let him step in at this point.
I would say thank you to everyone for participating to this excellent session. I think that we will have a break and prepare for the next one. Thank you, everyone.